All right, here we go with the lecture on the elderly and neurocognitive disorders. I love this picture because our elderly are really starting to be more active and live longer and doing lots of wonderful things like maybe jumping out of airplanes or parasailing or whatever this cartoon is showing. I think it's just great. So remember, this is a self-study to go along with the paperwork that's posted on Canvas under the module of handouts and looking at the elderly, just to give you some guidance. And this is very much review. That's why we're going to go through this very quickly, and you can just get refamiliarized with who are our elderly people out there. So technically, still 65 years and older is considered an elderly person. 85 years or 80 over is your older adult. Octogenarian. As soon as you turn 80, you're known as an octogenarian. All kinds of different names. We're living longer, doing better, and that's all good for us. So I understand that 50 is a new 30. That means I am in my late 30s, which is pretty cool. I like that. Don't feel like that, but I like it. All right. In terms of average expectancy, let me see if I can reformat this. All right. I'm going to have to do that. Okay. All right, there we go. So persons reaching the age 65 have an average life expectancy of an additional 19.2 years. 20.4 years for females and 17.8 years for males. So we're living longer. Half of older women age 75 or older live alone, and that's because most often they have lost their male spouses, if in fact they're involved with men. Almost 500,000 grandparents age 65 or more had the primary responsibility for their grandchildren who live with them. So that's sort of a newer phenomena in terms of our elderly, our older adults, and taking care of their grandchildren, actually being the primary caregivers and often sometimes taking custody. And about 3.6 million persons lived who are older. Statistic from 2011, let me bring that up to speed there, live below the poverty rate. And so this is a very, very difficult thing when you consider this, that persons that are retiring or forced to retire from work can no longer retire, are then placed on Social Security or whatever benefits are out there, and that becomes what's called a fixed income. And that's pretty devastating these days because our prices for everything to meet basic needs and what have you have increased dramatically, and it's not the set rate for fixed income individuals does not keep up with that, and so that becomes many more becoming poor or near poor. Pretty startling, and it says a lot for where we're at in this nation. All right, let's move over to the next slide. So what about mental health and the elderly? Let's fix that one. Sorry. Bear with me. There we go. I'll get it right. There we go. Okay. So mental health and the elderly. Where are our mental illnesses in terms of this population? And sorry for that again. I will continue to try and work with this. I am tired. There we go. Okay. So 20% of older adults, 55 and older, suffer mental illness. Oh my goodness, I'm 56. These rank as anxiety, cognitive, and mood disorders. So in respect to the different disorders out there, these are the top ones that persons of 55 or older will suffer in terms of mental illness. Psychosis increases significantly after 65. Okay, so this does not mean that everybody who's 55 or older will come down with one of these top disorders. The potential is just greater as we get older. And psychosis does increase, especially after the age of 65. Again, doesn't mean that people 65 or older are going to come down with psychosis. Suicide is definitely more frequent, and 75 to 95% of the nursing home residents are diagnosed with a mental disorder, at least 50% with dementia and depression, so 35% for depression. Dementia, think about that. That's the neurocognitive disorders we're going to talk about in the next topic there. 15% of those with chronic physical problems will have an accompanying access 1 or primary psychiatric diagnosis, most likely, again, depression or anxiety, given the rates there. Okay, so what do you need to do in terms of dealing with persons who have who are older? Normal change is expected to happen, will happen no matter what, going to happen. And so helping the elder to adapt is very important. So think about physiological changes. What are the normal physiological changes? And then you, the very young person, needs to tell this older person what those are and that they're normal. And they may think you're pretty ridiculous telling them that, but as nurses, we need to inform them of the normal physiological changes. Okay. So the RN is definitely going to help that person understand that through teaching. What is normal, what decreases, what deteriorates, and what are the losses, not loses there, losses. Ways to maintain physiological integrity through diet and exercise. So really promoting that and saying it's in your power. Certain things we cannot change, but there are things that we can change, and this is definitely in your power by changing the dietary and exercise. So then we go ahead and tell them about their psychological and behavioral changes, or we learn and know to recognize these, but recognize with this individual that there are losses, and this is a huge thing. We don't want to lose our independence. We don't want to lose our ability to function independently on our own, driving and what have you. Unfortunately, the physical changes get in the way of that independence. So there's many losses. That losses of family members. Look at the losses in terms of where families are these days, that they have to move out of their areas where they maybe grew up in because it's too expensive to live. So they're living somewhere else, great distances away from the elderly person. Elderly person thinks that's not a big deal because they're still functioning, but when they lose function and they don't have the support system here, it's very, very difficult. With those losses and the inability to maintain independence and get around, because now you maybe can't drive and you have to rely on public transportation and what have you, and we can't just say, oh, we'll get the Uber app, because these individuals are not looking at a phone and they don't have any apps. Okay, some do, but not a lot. And so they become very isolated. They can't get out of their place where they're living. Maybe they can't because of physical reasons as well. That isolation is deadly. Isolation is deadly for anybody who is depressed, who is an elder, because then you have nothing but your own thoughts to deal with all the time. And that can lead to very, very bad outcomes like suicide. Anxiety, anxiety over the losses, anxiety over the fact that they can't remember things, causes great deal of anxiety. So you name it, anxiety all over the place with individuals trying to deal with their advanced age. And then negative coping, using negative coping in order to deal with this. And that is also very tragic, because these elders will isolate and use alcohol or even medications, prescribed medications. They'll stockpile those. So it's kind of a bleak outlook for our elders, and we need to really figure out ways to support them and help them live out those so quote unquote golden years. Teaching. We want to teach memory preservation. How can you teach that? Think about those different strategies. One would be doing puzzles, just staying active, doing things as active as they can with their mind if their body's not behaving and keeping up with the world. Socialization. Older people, when they start to age, rarely want to go to a senior center because guess what? There's old people there. They're still not coming to grips with that they are old too. The senior centers offer so much wonderful opportunity to socialize and interact with each other. And it just in San Mateo, the San Mateo Senior Center offers great programs. I was just perusing through their calendar looking to see where to best fit in the blood pressure clinics that you all will be experiencing as second-year students. And the activities are amazing. I'm like, where can I put the blood pressure table or, have students go? There's too much activity. So I'm strategizing that. I'm trying to get it between 2 yoga classes. Is that crazy or what? Okay. Negative coping dangers, the dangers of substances, the prescribed meds, and not so much the street drugs, but don't put it past people of older age. They can get those too. Common disorders. Let me see if I can size that up without going into another slide. That didn't work. Okay. All right. Sorry about this. Oh boy. Okay, well, we'll just live with it. All right, common disorders in terms of this individual and what they're having to deal with or disorders of the older population. Depression. And you can use a geriatric depression scale. There is one that is in your textbook. I believe there's one on SimChart also to look at that. Or just Google it. You can see that there's some specific depression scales for all different ages, and this one in particular, since we're talking about the older adult, is an older adult one. Suicidality, remember those statistics I just talked about in the previous lecture. Substance abuse, the negative coping, using substances for the isolation, and what do you know about sundowning? So right now, take a little venture off this and go ahead and Google what sundowning is if you don't know what that means. And it's very, very important to know what that is in terms of going into med-surg, and if there's a fair amount of evening shifts, you will see sundowning. Need to be restrained due to their delirium or their dementia. That is something that we tend to do to our elderly, and how good is that when they have fragile skin and fragile bones? Could be very harmful. And there that is. Okay. And then let's look at, and I'll size that up there, some former names for when a patient gets into delirium or dementia. We used to call that organic brain syndrome or an organic mental disorder. According to the DSM, a cognitive disorder, so that's what we're going and looking at right now in terms of cognitive disorders with individuals. Sorry, if I showed you the top of the slide, you would see cognitive disorder. However, your textbook in DSM-4 or 5 is now calling that neurocognitive disorder. All right, so what is a cognitive disorder? It affects learning, memory, problem solving, and perception. Although other mental disorders, anxiety, mood disorder, psychosis, also affect the cognition, the DSM does not consider these to be cognitive disorders. So a neurocognitive disorder is dementia, delirium, or amnesia. For the purpose of this lecture, we're going to stick with dementia and delirium. And here we go. Okay. So delirium versus dementia. We're looking at this slide, and I'll scroll down so you can see all of it as we go along. Delirium is a state of cognitive impairment and confusion, usually of recent onset. In bold, or excuse me, in highlight in red, related to another illness or stressor. It is not, it's short-lived. It comes from something else, and once that something else is gone, it goes away. Dementia, on the other hand, is an irreversible state of cognitive impairment and short-term memory loss related to organic brain disease. Most commonly, dementia is related to Alzheimer's. That's the most common one that we know, but there are so many other types of neurocognitive disorders in terms of or types of dementia, and that's really important for you to review those. Note, I said really important for you to review those. So go to your textbook on this chapter and differentiate between those. So you have an understanding. You're going to see a lot of this with our increasing population. So aside from Alzheimer's, there's other ways you can get dementia, and those can be, so Alzheimer's would be called a primary dementia, and other ways would be multiple cerebral infarcts, would be known as a secondary dementia because you have a lack of blood flow to the parts of the brain. Okay, next slide actually has this in terms of what is a neurocognitive disorder, pardon me. And let me size that up, get that into the frame. There we go. Okay. So abnormal psychological or behavioral signs and symptoms in which the origin lies in medically identified cerebral diseases or dysfunction. Delirium and dementia are examples of two cognitive impairment syndromes. Amnesia is another one. That's it. So some people will think schizophrenia is a cognitive disorder. It might have some issues. Some people may have some issues, by and large temporary, with the cognition. It is not a neurocognitive disorder. Okay? We've got that, right? Very, very important to know. Year after year, students get this very much confused. All right, so incidence in terms of who gets this. The U.S. Congress, Office of Technology Assessment estimates that 1.8 million Americans have severe dementia, and another 1 to 5 million Americans have mild to moderate dementia. Our aging population is increasing, and there's going to be a lot more of this, so we have to really think of strategies and ways to help people live their lives with dementia. Okay. So you can see the rest of the statistics there, and I'll let you take time to read that. You can pause the screen and then go ahead and read through this, but I'm going to move on to the next slide. All righty, etiology of the neurocognitive disorders. Again, let me see if I can bring that into frame. There you go. Delirium. Talked about that being related to something else. This something else, an example here would be drug-induced delirium, and very, very, very common to see that in patients who have had surgery coming out of anesthesia. The anesthesia is still on board, and then we give them pain medication, and we give them mind-altering types of pain medication, not intentionally trying to get rid of the pain, but on some people it really alters their mind and gives them a delirium, or they're in a delirious state. If it's not drug-induced, just stay up for days or hours, and you too will become delirious. Or have a high fever, you too can become delirious and experience some really profound effects with that. And then we also look at our person who's coming out of alcohol withdrawal. They're in delirium, again related to a substance. Dementia, as in Alzheimer's disease versus vascular disease. So Alzheimer's is, the thought is related to the neurotransmitter acetylcholine, and certain areas of the brain are being studied in terms of where that Alzheimer's or that type of dementia originates in the brain. Some are caused by vascular problems. Remember, so Alzheimer's is a primary dementia because it originates in the brain, as do vascular, but it originates in the vascular system or something causing those infarcts. And usually that's from plaque buildup or little clots and what have you that travel there, high cholesterol levels and things. And that's why it's known as like a secondary. In any case, know what causes delirium. So substances or any other cause, short-lived. Otherwise, it's not called delirium. If somebody's having those effects, those neurocognitive issues, and it lasts and lasts and lasts, it's likely a dementia. So dementia is irreversible. It does not go away. It lasts forever. It gets worse progressively over time. And we look at these types in terms of examples, Alzheimer's disease versus a vascular disease. And again, look at your textbook and see how other ways one can get dementia. Okay, it's not just Alzheimer's. Good. I think we got that clear. Okay. Behaviors that are associated with neurocognitive disorders, sensorium and attention. So mood changes rapidly accompanied by physical behaviors. And this is why some people who are delirious will have aggressive behaviors, act very, I'm trying to think of the term, it's escaping me right now. But those that have Alzheimer's or dementia, they can have mood changes, they can have some behavior issues. Decreased concentration. So these are some assessments we're making with this individual. Disorientation, excuse me.
Hello there.
Okay, so disorientation makes interviewing somebody it's very complicated to do that. All right, next slide. And what are we looking to in terms of perceptual? What's going on with this patient? Hallucinations, delusions of paranoia, less likely of grandiosity. That kind of fits with our bipolar patient, but certainly delusions of paranoia. And we see that in our elders who are experiencing dementia, where it's common to accuse people of stealing money and what have you. Hallucinations with that sundowning patient, that person that phenomena of sundowning will have vast hallucinations, but hallucinations will really, really fall into the category of delirium. People with delirium will have hallucinations, profound hallucinations. Memory is a big one, impaired. Short-term impairment over long-term. So again, that when we talk about therapies, reminiscence therapy is very important because patients with memory impairment who have dementia will have a more intact long-term memory. And then we are looking at this in terms of understanding these are, in terms of dementia, a degenerative process. When our brain tissue is becoming less, because as we're aging, we're losing neurons, this is irreversible and not replaced, at least not yet. They don't regenerate, but there's hope because they're doing a lot of studies with growing new cells through just manufactured stem cells that they take just from rearranging not stem cell, but any type of cell, and changing it into the cell that they want it to be, that they being the researchers. So stay tuned. There's a lot of good research going on there. Not that I want to live any longer, that's for sure. When I get older and my body's going, I think I'm ready to go. Not anytime soon, though. Okay, here we go. Nursing process, assessment. Diagnostics, we can definitely look inside the brain now, so much better than before. With Alzheimer's, you couldn't really see anything until autopsy, so this is good. We can now see things before and look at the brain structures in terms of their shrinkage. What kind of space do we have available now inside the cranial vault, because the brain tissue is shrinking. MRIs tell us that. SPECT scans, these are nuclear imaging that looks at blood flow. So if there's a lack of blood flow to certain parts of the brain, very, very helpful in checking our patients that have maybe some vascular issues. And then PET scan, nuclear imaging, looking at brain activity and where our brain thrives on glucose. I know that's really a good thing to hear for some of you that might be right now eating something that's kind of sugary while you're listening to this lecture. Your brain needs that. Okay, and the PET scan sees where that glucose activity is, so that's important. All right, and then other diagnostic tests. One thing that's not up here that you might see in terms of vascular problems, a cerebral angiogram can be done to look at the blood flow really very nicely through a cerebral angiogram. That's pretty invasive, and so MRI might be better. There's also MRAs, those are magnetic resonance angiography. That does not involve sticking somebody with a catheter up from their groin into their head. So eliminating the actual invasiveness of that. Mental status exam is something we're definitely going to use. And physical exam, got to look at that. And labs, looking at lab values to rule out other causes. All right, so your nursing diagnosis begins with we did our assessment, and then we're looking at our highest priority. Risk for injury, trauma. Patient will remain safe without injury. That is a huge and high level prioritized nursing diagnosis and outcome. Fluid volume deficit. Now, typically, a lot of older people become quite dehydrated for some reason. Again, a normal aging process where our thirst centers will not be as active, and so somebody can get quite dehydrated. Now, they also we have to watch pumping fluids into our older person, because what comes with age is congestive heart failure in some people too, and we don't want to overhydrate them. So that can be a difficult little dance to dance there on that one. Disturbed thought processes. The patient will remain safe while experiencing delusions or hallucinations. And impaired memory. That's a nursing diagnosis, and so you can look at also chronic versus acute confusion. Acute confusion would apply to your patient with delirium, and chronic confusion, your patient with dementia. Take a look at those nursing diagnoses and the care plans through either SimChart or ACLY or any other resource and see exactly what the interventions are for those. They're pretty different. Maintain reality orientation to the best of his or her ability in terms of impaired memory. We're not going to hold them accountable for knowing who the president is, what day it is. I mean, we're going to hold them accountable for knowing their name, and that's about it. Because asking them too much or setting a goal of their memory will be restored is a little bit too much to ask, especially with your demented patient. Your delirious patient may, in fact, actually know that. They're pretty good at looking at calendars, too. Both of these patients are. We'll give them credit for that one. The ability to look at a calendar. Okay. All right, let me get back into this next slide here. Oh, okay. All right. Yes, I'm having difficulty with that. So sorry for taking you all over these slides. I'm tired. This is late. This is after lecture. This is like 9 o'clock. Oh, no, it's 10 o'clock at night. All right, so some other nursing diagnoses. Altered thought process. We will have a goal of validation and reminiscence versus orientation to person, place, or time. They'll be able to reminisce about their past. They'll be able to validate who are people in their lives. Through validation, we will show them pictures of their family and friends and significant people in their lives, and those may be placed in their room. That's a good idea to have that so they can kind of connect and remember who these people are. Altered family coping is so hard on the families, especially working with a demented patient who is progressively going to get worse. They need respite. So we're going to make sure that they are offered respite and that they achieve respite. They get some rest over this. They're not always having to take care of this individual. Unfortunately, that's the way it is for a lot of people. They have to take care of their loved ones. Putting them in a long-term care facility is not an option. It's too expensive. So risk for other directed violence. They will not harm others, specifically looking at persons that have dementia, they have violence issues with that, or they have delirious problems. Those with delirium can also be quite aggressive at times. Sleep pattern disturbances, they will establish an adequate sleep pattern. This is so important. Regular sleep is only helpful to these situations of neurocognitive disorders. Okay, here's your chronic confusion NANDA nursing diagnosis. Go ahead and pause the screen and take a look and relate it and take a good look over on this nursing diagnosis. Let me see if I can put it into the screen for you a little bit better. There you go. Go ahead and pause that because I'm not reading all this. You can definitely take a look. Okay, and then I'm going to move on to the next slide. And then versus the acute confusion. So talked about that, and again, take a little bit of time to look at this and see what the nursing diagnosis says, the related to, evidence by, nice of good handy information there. And your interventions. What are these interventions and what do they entail? So right away, start and assess the current level of functioning. So important. Where are they functioning now? Especially with our demented patient. We want to know where they're at because that's going to help in terms of what they can or cannot do. If this is acute, if this is a delirious symptom or a problem, then you need to treat the underlying cause. That might be just letting somebody detox off a substance. Or pay attention, is this the pain medication they're getting post-op? You're going to see this, guys, you're going to see this as you move into the next few courses. So take a look at that. If you notice behavior changes after somebody is pushing on their PCA pump, you may have a problem here with somebody having problems with the narcotic. Interventions, making sure the environment stays safe. Got to really look around and do that. Reassurance, if this person is hallucinating, they're having delirium, we have to let them reality test with us. They'll say, do you see those spiders all over the walls? They're coming at me. Whatever, we need to provide reassurance to that individual. Explanation to the client, patient, and or family caregiver of what's going on in terms of delirium or with the dementia. And reorienting, especially with the acute patient, the patient that's experiencing delirium. Reorienting the person with dementia is going to be a waste of time. Okay, that's just really going to be a waste of time. Having family pictures around and helping them see who are in those pictures and talking about those individuals will help to reduce the depression and anxiety that individual is experiencing because of the dementia. And maintain this normal sleep patterns. Let's not forget about elder speak too, and talking to this individual in appropriate ways. Okay, I think I bypassed another set of interventions, and here we go. There's the elder speak. Alrighty, so let's get this slide in full view. Health maintenance, monitoring labs, meds, elimination patterns, etc. You need to be on top of all of that. Could be a very big safety issue if we're not getting somebody up to the bathroom every couple of hours. They might be trying to get over those side rails themselves to do that and then end up falling. Again, providing the family with support networks that are out there in the community for respite, meaning that where, there's the adult day health centers, if that person is able to get into a Ready Wheels or other type of van that can transport them, they can go to adult daycare centers. They're in every city in our county for elders to go to. So this is a wonderful, wonderful opportunity for respite. So again, people are taking care of their elders. Or they're hiring caregivers, extraordinarily expensive. Maybe a little respite give the caregiver a couple days off and invest in looking at the Investigate looking at the adult day health center if that's available, or if they're taking care of people or their elders, 24/7, maybe offering some, a service that can provide a caregiver for a few hours a day to give them respite. Oh my gosh, that's important. Can you hear it in my voice? It's so important. And really helping the family cope, because when somebody is demented and they don't remember who these people are in their family, the family feels very, very bad about that. So it's important to pay attention to them as well. This would also apply to our delirious patient in terms of helping the family understand what's happening with that individual. We want to provide socialization and independence, and so we often want to put our people that are older in older people's homes, like the skilled nursing or assisted living, where they're surrounded by a bunch of other old people. And I say that because they love to see younger people. So I want some of you, as you get into your years as a nurse, and I want you to really get together and create some assisted living homes where younger people can also live, and where younger people can play cards with them and eat with them and socialize with the older people, because they need to see younger faces. It gives them great joy, really gives them great joy. You know this when you talk to older people, or as I said, second year students go into the blood pressure clinics, and you are going into senior living or senior centers, those where seniors frequent, and engaging with them, and they absolutely love you. They love, love, love talking to you. Communication, important there. Elder speak, again, we talked about that. Read up about reminiscent and validation therapy. Very important to know about that. And then community resources. They are out there. It's up to us to kind of look into that and talk to our elders and their family about some resources that are out there for them. There's so many more interventions that are available to people, those unique individuals that have unique needs. And that's it. That's the end of this lecture. And I wish you well. Good night, good day, whenever you're reading this or watching this.